Hello, this is your brain on drugs, and this is the punk rock psychiatrist. So today we're going to have part two of the November updates. We went over several papers and things that it came out in the last update, and I had a whole bunch more of them, so we're going to cover those today. All right, so let's get started. Um, you know, in the September updates, I actually talked about a new medication called Seltorexant. So if that orexin sounds familiar, that is a orexin receptor antagonist, but unlike this one's, if you remember, is not a DORA, a dual orexin, so orexin 1 and 2. It's actually a selective to 2, so it's a 2 SORA, not a DORA. And we had talked about how there was some phase 2 data showing that it was helpful for sleep and that phase 3 trials were ongoing. Well, we have phase 3 data came out already. So what the phase 3 data showed was that it was equal performance with quetiapine for depression and insomnia with less adverse effects. But I don't know, I kind of find it interesting. When you read the article, it basically says it's not better than quetiapine, right? So it's not more effective, as if that's a bad thing. It's like, oh, it didn't meet the endpoint of outperforming this other drug. Well, I mean, you didn't put it up against a placebo. You put it up against a medication that we know works for depression and that we know works pretty well for insomnia. So I think the fact that it was performed equally well to quetiapine, and we know how quetiapine has all these adverse effects, and it has such adverse effects that the FDA did not approve it. And I think it was anxiety, not depression, that they were trying to get approval for. Um, but the FDA, even though it would had a effect size higher than almost any medication that we have, they were like, oh, the adverse effects, it's not worth it. And so quetiapine is actually a pretty effective medication for this, and it's pretty effective for sleep. But once again, it's not going to be approved for that either because of all of its adverse metabolic effects. Um, and so the fact that Seltorexant is equally good, and of course we know that there aren't really any side effects to this medication, or to the doors anyway. There's not really any side effects, so I think this is a really good thing. So I mean, I think you're definitely going to see Seltorexant out there. I'm still not sure what this selectivity towards the orexin 2, theoretically maybe, but what what practical difference is this actually any different than the other ones? Are we avoiding something with the orexin 1, not having that? I mean, the other ones are also doing 2, so we already have something that's doing this. I think we're going to have to wait for this to get approved and kind of see how it's used to see is there actually an advantage of this being selective for the orexin 2 receptor. But I think this is pretty good data on this phase 3 trial here. All right. We had an episode about the ketogenic diet a few weeks ago, and it's a very controversial topic. I think I'm hard on this diet because I am skeptical that this is practical and also cardiovascularly safe and so forth. But I'm also optimistically excited that it could help patients that are not getting help from anything else, that have severe mental illness, whether that's severe depression, schizophrenia, bipolar disorder. If you've got a patient that is capable of adhering to this diet and nothing else has worked, and they want to try this, they're able to try it, and they're suffering that much, and the drugs, they either just can't tolerate them or whatever, I'm in favor of giving a trial of this. And so this is actually exciting here. Most of the studies out there that we have so far are for schizophrenia, maybe some bipolar disorder, but here's one for major depressive disorder. Okay, so this is entitled A Pilot Study Examining a Ketogenic Diet as an Adjunct Therapy in College Students with MDD from Translational Psychiatry 2025. And let's actually go through some of the information here because I think it's pretty good. So depressive symptoms decreased by 69 to 71% within 2 to 6 weeks in a 10 to 12 week intervention. That's a lot. I mean, I'm not, 69 to 71%. I mean, I don't know if our medications can do that. Global well-being increased nearly threefold. That's massive. Um, and then they had the 6.2% weight loss. So, we know that that was the main reason we were talking about it, because in weight loss. So, saw some weight loss. That's often a good thing for folks that need to lose weight. And this is cool, 13% fat mass loss. So even though they didn't, so 6% weight loss is not massive. Like typically I'm wanting to see like 10 to 20% depending on the size of the patient. But 6% is really, it's better than nothing. It's better than gaining weight. So, I mean, it's a good result. But a 13% fat mass loss, that means that they're losing more fat than they are lean muscle or lean tissue. So that's what that says to me. And so, like, even if you only have a little bit of weight loss, that weight loss is coming mostly from fat, which is a good thing. And then a 52% leptin decrease. We talked about leptin in a recent episode, and how, when you eat ultra processed foods, your leptin signal can become, it's kind of like it's not sensitive to it. Um, and then it increases because it doesn't realize what it's supposed to do. So, 52% leptin decrease, that's going to help maintain metabolic health. And then BDNF, brain derived neurotrophic factor, 32% increase there. That's really healthy stuff for our brain. Therapy increases it, exercise increases it, antidepressants increase it. So it's increased pretty much by most of our interventions. And to see a 32% increase with the ketogenic diet, that is a really cool thing to see. There was an improvement on cognitive tasks. So they're thinking more clearly. And then there was a case series that showed, and this was separate. This was not that study, actually. I found another case series that showed improvement in anorexia nervosa. So, these are folks that, like, we have really not really any good treatments for. They're very resistant. And to see a case series here that went on the ketogenic diet and it helped with anorexia nervosa, because, we're thinking about losing weight with the ketogenic diet, but like it's really improves metabolic health in a lot of ways. And so I think when you've got an anorexic patient, the fact that could help with them, I mean, it's only a case series, but that's really promising. So I think that's all really exciting information. I read an article recently that, said is the ketogenic diet the GLP-1 for psychiatry, right? Is this like going to be like our big thing that changes everything? I mean, there are centers opening up, and Stanford's got one. I talked about this a lot on that ketogenic diet episode. So while I don't like the idea of everyone on this diet, I think for those where the benefit outweighs the risk, like in the severely mentally ill, if they can adhere to it and it helps, that the benefit likely outweighs the risk. Because, having severe mental illness that's not treated is really, really bad. And the fact that this actually can help with that. And at the same time, if somebody wants to do this diet and they think it might help their mental health and they think it does, I'm not going to tell them not to. I'm going to caution them of the risks. And, we can monitor cholesterol and things like that to see how they're doing. But I think this is research we need to do. And we don't have, we don't have a smoking gun, or a silver bullet, not a smoking gun. We don't have a silver bullet for treating mental health. So I'm excited about the ketogenic diet, actually. And that's why I did that episode on there. But like, I am cautious. All right. So moving on, here's another one. This is interesting. This is a new medication. This study is entitled Single Treatment with MM120, otherwise known as Lysergide. I'm not, Lysergide. Is that guide, jide? I mean, I'm not sure. In a GAD, generalized anxiety disorder, a randomized clinical trial from JAMA Network 2025. And this Lysergide guide, I don't know, however you want to say it, is it's an LSD containing drug. All right. So, we're looking at all these psychedelics. They're looking at mushrooms. They're, psilocybin. They're looking at uh, MDA. Um, they're looking at ibogaine, which that one I've really seen some pretty incredible stuff on ibogaine for like treatment of like opioid addiction, PTSD. That one's pretty exciting to me. I've seen the most incredible results from that, and I like the ibogaine because it's just like really a single treatment. I mean, you might get a couple of doses, but it's like over a day or two, and then that's it. It's not like the psych where you're getting the therapy while you're on the medication kind of thing. And then of course, ketamine. I mean, we could think of that as kind of a psychedelic as well. I mean, it's a dissociative. It's similar in many ways. So, this is a new medication that has something to do with LSD. It says LSD containing drug. So there was a significant dose dependent reduction in anxiety. I wasn't able to get like actual numbers out of it, but it was significant and it was dose dependent. Like the numbers they kind of confused me, but they were an improvement. So, this is LSD is what? It's a 5-HT2A agonist, I believe. So this is something that could turn into something. So, I mean, we hear a lot about the psychedelics. I haven't seen a lot of stuff on LSD, and I certainly haven't seen this lizard guide. Um, I don't know, lizard guy. I mean, what are we going to call this thing? Um, we'll see. So that's some interesting stuff going on there. Next, so we talked about lecanemab. I think on the last episode as well, the last update episode, it's a treatment for dementia, um, and it requires the MRI screening because you can get cerebral edema, right? So I think the aducanumab was the first one that came out, and it was kind of like, oh, is this? It's really really expensive, and it doesn't even really work that well. And the FDA kind of approved it before it looked like it worked. And remember what this thing is? It binds up the amyloid in the brain to kind of get rid of it. But then there's this idea: is the amyloid the problem, or is the problem causing the amyloid? So lecanemab was the second of those medications, and it seemed to work a little bit better. But now they're saying the FDA is now requiring to screen with the MRI sooner. All right, I think it was about 4 months later, and now they want to do it a couple months after starting it. And this is part of what makes this medication so expensive is the need for these MRIs to screen for this brain swelling problem, right? So just wanted to let you know that they did change that, and so maybe the signal is that like, oh, there's a little more risk here than we were hoping for, um, and that that relates to geriatric psychiatry, so and neurology, something that we have to know about. So we'll update there, and then let's keep going. Next, so we've talked about when we went through the depression series. um, we mentioned some of the like medical causes of depression, and one of them was montelukast. So that's Singulair. It's a medication used for asthma, um, and I believe it's got a black. It's one of the few medications that has a. I believe it has the black box warning. I mean, the antidepressants, of course, have the black box warning for suicidality or neurocognitive, neuropsychiatric effects or whatever. Montelukast has got that as well. It's one of the few other ones that does. And some new reports coming out here, um, that there's more than a fourfold risk of neuropsychiatric events on montelukast in children with a psychiatric history. So if you already have a psychiatric history as a child and you've got asthma, you are a fourfold increased risk um, from montelukast compared to those that do not have a psychiatric history. So maybe that would be a population that we would perhaps not want to give it to, right? Um, we're already there's already like, because we've found out about this, that I think they were doing Monte Lucas for things that were not asthma, like things like allergic rhinitis and things like that. And they're like, no, 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 don't do that. One, it doesn't work, and there's these risks, so like, let's not do that. But for asthma, it is, I believe that is the one thing that you can use it for. But if you've got somebody and this is just in children, so we don't know, like for adults, what might their risk be as well. So good to know. Oh, and here's a short one. Here's a nice little update. Lumateperone, right? Caplyta. That's not our no longer our newest medication for schizophrenia. That is the newest one is the what is it? Xanomeline trospium. Um, the name of the name is escaping me at the moment, but yeah, xanomeline trospium. That was approved about a year ago. Lumateperone came out like a few years before, and is it was unique in that it's not really a direct dopamine blocker. It goes through the serotonin. Was it 5 is it a 5-HT2C antagonist? I may be wrong about that, or 2A or something like that. But works that way, and so it's got less of the adverse effects. Well, it just got approval as an adjunct for a major depressive disorder. So that's cool, right? Because I think what we've been doing for major depressive disorder, oftentimes when the antidepressant's not enough, we're adding, in many cases, aripiprazole, quetiapine, um, maybe lorazepam, right? So we're adding some of these medications, but they do have a lot of adverse effects. And lumateperone, it does not have so many adverse effects, and not the same ones, certainly. So now that we have this FDA approval to use as an adjunct for MDD, I think we're going to see a lot more folks out there reaching for lumateperone instead of aripiprazole. Now, of course, it it probably costs much more, but it's probably a better medication. Now, I mean, we need some head-to-head trials to say, adjunctively. Like, the thing is, we already know that what was the the effect size for adjunctive treatment of antipsychotics for MDD. It's like 0.2. It's really poor, right? And so, like, I'm not a big advocate for this in the first place. I think you need to have maybe some other things going on, maybe some other signs, maybe you try it, but it's certainly not. I think we reach for these antipsychotics way too frequently. Um, they do really help some patients, so it's not something you would want to avoid completely. But I think now that we have this option to go for lumateperone, even if the effect is minimal, if it adds something in you're also, remember, adding placebo, right? Because now, oh, we're taking a new medication, we're taking a second medication, so you're also adding some placebo as well, to be able to add something that doesn't have all of the adverse effects that the second generation antipsychotics have. I think is this is a really good thing. So, and now that it's going to be approved, that means that insurance will pay for it. All right. So this is great. Could have used it off label, of course, before, but then, you run into the problem of insurance not paying for it. All right. So let's go. We've got another article here. So this article is entitled Association Between Hyperemesis Gravidarum. So that's the condition in pregnancy where uh, patients just, it's like morning sickness on steroids, where you're just vomiting constantly, and it gets so bad that patients often have to be hospitalized because they're losing fluids. So association between hyperemesis gravidarum and depression, a national register based controlled study in Finland from the Lancet Psychiatry, November 2025. All right. And I think it makes sense that if you had hyperemesis gravidarum, that you might be at greater risk for depression. I think any kind of like negative thing going on during your pregnancy is going to increase your risk of like postpartum or peripartum depression. But now we have some data on this, and it's actually pretty significant. Look at this. So according to this study, and this is a registry study, so this is like one of those, like, we love these I love these I love the Scandinavian countries in general. I've never been to Finland. This is the only Scandinavian country I have not been to, and I really want to go there. Um, Probably that's on my list for next year. So I love Finland. I'm a hockey fan, and a lot of Finnish players in the NHL, and a lot on my team, the Dallas Stars. So I've I've had Finland on my list for a while. And so this is, you've got tens of thousands of patients, basically, like, because they have, like, the Scandinavian countries keep track of, like, countrywide data. They know everyone that's had these conditions, and then they can just, like, look at that data and be like, who had this, and then did they have depression or not afterwards. And then we have just, like, this great data, right? Remember, it's not a randomized placebo-controlled trial, but it is certainly, um, uh, gives us good information nonetheless, right? Especially since we have such huge numbers. But correlation is not causation. We talked about this last time. All right, so here, 8.8% of patients that had hyperemesis gravidarum um, had pre-pregnancy depression. So, and then compared to 1%. So that means if you had depression before you were pregnant, there's, like, what is this? Almost like a ninefold chance that you're going to get hyperemesis gravidarum. So, like, having depression increases your risk for this in the first place is kind of what it looks like here, right? Because you've got, like, 8.8% of patients that had this hyperemesis gravidarum had depression before they were pregnant, versus 1% of patients with hyperemesis gravidarum did not have depression before they were pregnant. All right. And I don't know, does that mean that if it was well treated before, that maybe it decreases your risk of hyperemesis gravidarum? I don't know. But it certainly shows a correlation between the two. And then when we're looking at, did they have new onset diagnosed depression? So they did not have pre-pregnancy depression, but they have peri or postpartum. Okay. And really, postpartum is, I think it's more appropriate to call it all peripartum. So peripartum would be, like, just during the pregnancy time, and that includes the time after pregnancy. So I like the term peripartum, but just so people kind of understand that post is included in that, just to kind of make that clear. So we're looking at folks that with peripartum depression that had a new onset depression, patients that had hyperemesis gravidarum versus those that didn't. All right, so 4.9% of patients that got hyperemesis gravidarum that did not previously have a diagnosis of depression were diagnosed with depression. Okay, versus 1% of patients. So 1% of patients that did not previously have a diagnosis of depression and did not have hyperemesis gravidarum got a new onset to peripartum depression. So there's about a five-fold increased risk of new onset depression if you have hyperemesis gravidarum, and about a ninefold increased risk of getting hyperemesis gravidarum if you had depression before. So it seems like there's a big association between the two here, right? And so, I mean, I think I know. I mean, what you do with this is, you've got a patient that has hyperemesis gravidarum, and you're going to be a little bit more vigilant for depression in that patient. Maybe ask the questions with a little bit more, like you're expecting a different answer, and instead of just, like, kind of breezing over it. Like, they got the screening questionnaire in the hall, they said no to everything, and then I just drop it. No, well, if they had this, maybe I want to be like, hey, how have you been doing and stuff, a little bit more, like, a little bit more expecting that something may have happened. But once again, I mean, this is not everyone. I mean, 4.9% versus, like, that means that 95% of people who get hyperemesis gravidarum don't get depression, right? So the vast majority don't. But the vast majority of folks, I mean, didn't get it that didn't have it either, right? But you are at an increased risk, all right? So, I mean, that actually seems kind of small to me. Only 1% of patients got new onset depression that did not have hyperemesis gravidarum. I mean, I would think the incidence of peripartum depression would be much higher than that. But regardless, just kind of take away from this that the risk is higher. All right. All right. Let's move on to the next, um, our next paper. All right. So what we've got here is it's titled "Menstrual Psychosis with a Marked Response to Carbamazepine." This is from Psychiatry and Clinical Neuroscience Reports from 2025. And I think what's interesting about this one is this is just one case, right, um, of menstrual psychosis. And I just bring this up because this is not something I think that most people are familiar with. So it was actually pretty interesting if you want to read it. This was a teenager who would become psychotic basically during the premenstrual part of her cycle, and then like after she finished with menses, like it was like premenstrually she would become psychotic, during menses, and then once she stopped her period, she would not be psychotic anymore. It just resolved on its own, and then it happened every month. And I don't, it depends how they're kind of measuring this. And, is this actual real psychosis versus, is this just like someone who's got really, really bad PMDD and so forth. But I mean, I read the case and she certainly did sound psychotic. And so I think it's important to know about stuff like this because, in my career, I ran into some situations that like I had never learned about in my residency training. And I was just like, can this happen? It seems like this is happening. Is there a precedence for this? Like I had a case of a guy who um, he became psychotic um, when he was withdrawing from alcohol, but like quite a bit later. And it was just like I had never seen anything that severe. I mean, it wasn't just it was like, but he was like manic. He was psychotic. It was like severe. Um, and so I called up, I called up an old instructor and asked him. It's like, oh yeah, I've seen that before. It's like there's things that you may not have been taught or seen during residency, and they're just really rare things. And I think it's important to know that they exist because like then you're vigilant. Then when you see it, you're like, okay, I've heard of this. All right, so apparently could happen. And it's also interesting that like they found that she didn't really respond to like antipsychotics and antidepressants, but she responded to carbamazepine. I don't. This is in Japan, so like I don't know if they use carbamazepine in Japan more. I know we barely use it at all in the U.S. I think it is a very challenging medication to use, but like I think that we've gone towards using it less to less. Like I think it does have a place, and people just don't think about ever using it now. And I think now that we have like valproic acid getting to a point where the time to use that is really limited because of now we have with the ca- causing issues with men as well in their offspring, it affecting their sperm. Having something like carbamazepine maybe should be bumped up in the algorithm above valproic acid, and this is something that we should look at using. Now it is, we haven't talked about carbamazepine yet, but it has a ton of black box warnings. It causes granulocytosis. It can cause, um, uh, it induces its own metabolism. So it's like, it's challenging to dose. It is an inducer in general of 3A4. So it interacts with a ton of medications. So it's not for the light of heart, but we don't have a lot of mood stabilizers. So we have like basically three. And so maybe there are probably times where we should probably be reaching for this in patients that don't respond to lithium. Maybe this is something we may be thinking about. But interestingly, They found that this patient with this one particular patient with this one particular unusual menstrual psychosis that they diagnosed her with did respond to it. And so if you see a case of menstrual psychosis, or maybe you're thinking out there, oh my gosh, maybe I have seen that and just didn't realize it because I had never heard of it. And what I'm done for the patient hasn't really worked out. Maybe I'll try carbamazepine. Who knows? Maybe that, there's no studies on this, but we have a case where it helped. And when you've got a condition that we don't really have any FDA approved treatments for, or any studies about treating, what makes the most sense is to use something that has worked before, and that's why you should be publishing um, if you find something unusual. So kudos to Morisaki et al. For publishing this article. All right, next one. Oh, there is a new ADHD medication potentially out on the horizon. Currently, it's called CTX 1301. It just had some positive phase 3 trials. It's hard because it's in trials, and it's like, the company is not releasing that much data on it. What I was able to find out is that um, it uses this new patented technology called precision timed release with like a little trademark. That's their trademark term, and they've also trademarked PTR, the abbreviation for precision timed release, and it releases 3 doses to give a full day coverage. I think it's a methylphenidate product. I didn't put this in here, but I believe that's what it was. Um, I don't know. Perhaps it's smoother than Concerta. Concerta is also a triple dose medication. Um, does it last longer than Concerta? I don't know, but it's got some positive data. It's got a new release system. Perhaps this will have a place in the pantheon of a million ADHD medications that we're discussing in the ADHD series. So, just to let you know, there may be a new ADHD medication out there, and it uses this new technology, which I don't know what this means. So, once and if and when it gets FDA approval, we will know more about it. But I like to keep you guys aware of what's on the horizon, so that when it comes out, you won't be surprised. You'll be like, oh, I've heard of that. Let me learn about that. All right. Oh, this was a really cool article from Pillinger et al. Entitled The Effects of Antidepressants on Cardiometabolic and Other Physiological Parameters, a Systematic Review and Network Meta-Analysis from the Lancet 2025. I liked this article because whenever we talk about the antidepressants last year in the first season, um, one of the things I like to do is kind of differentiate like what makes one antidepressant different from another, especially when they have very similar mechanisms of action. And what I liked about this paper was it took a ton of studies, it pooled all these patient data, and it looked at all of these adverse effects. And I learned some things from this that I did not previously know. So and then I just wanted to highlight some of the interesting findings, but like I would encourage you to look this article up yourself, because they basically show the difference between lots of different meds. Now, the difference between meds on a lot of these parameters weren't terribly different, which is also relevant, but I'm going to tell you about the stuff that was kind of different. All right. So when they looked at weight gain, escitalopram was the highest SRI, serotonin reuptake inhibiting medication. And that's something that I have talked about before. And I had previously thought it was paroxetine, maybe even sertraline was worse. And I was actually surprised because escitalopram has been my go-to SSRI for a long time. And in the last year or so, I've found out that it's perhaps causes more weight gain than the other ones. And I've seen that, because I put a lot of patients on it, and I've had a lot of patients complain about weight. Now, is the difference between that and another one going to be that much different? Maybe 5 pounds worth. But I mean, that is a difference. Okay. So, and then kind of in order of increasing, oh, and actually it wasn't the worst SRI. We'll mention that here in a second. And then kind of an increasing from there, um, trazodone was more. Mirtazapine was more than that. Talked a lot about mirtazapine. Trazodone's not one I really think about weight gain. So that's a little surprising. It beat out escitalopram. Mirtazapine beat out trazodone. And then fluvoxamine actually was higher than mirtazapine, which that was really surprising for me. I don't use fluvoxamine. I don't really care for fluvoxamine. We've, go back and listen to the episode where I talk about it if you want to know why. But I'm really kind of surprised that the weight gain was higher than mirtazapine. Just another reason to not like fluvoxamine. And then this is also surprising. Milnacipran was above fluvoxamine, which I really found intriguing because I think of the SNRIs as not causing weight gain. And when you looked at the other SNRIs, they were much lower. And so I don't know if this was just like one study with only a few patients and it just, didn't really match up with the other data. I don't, and I mean, nobody uses milnacipran. It's not approved for depression. It's approved for fibromyalgia. I've never seen it used anyway, but just kind of interesting to note that it may cause weight gain. And then the tricyclic antidepressants, which is not surprising, were the highest. All right, and then they looked at cholesterol, and in kind of increasing order, of the ones that were like significant in that they did cause an increase in cholesterol. Most of them did not affect it. So paroxetine was a small increase, and then higher than that was duloxetine. And this, someone told me recently that they were on duloxetine and that increased their cholesterol. And I was like, wow, that's unusual. I've never heard that. But here, this study like shows it. It does, and it's one of the highest. But beating out duloxetine was venlafaxine, and then beating out venlafaxine was desvenlafaxine. So that one was actually desvenlafaxine, or Pristique, was actually the worst for increasing cholesterol. And I don't even know, like, what is the mechanism of this? I mean, these are three medications. I mean, paroxetine, I can kind of see, like, it increases appetite, it makes people drowsy. I mean, it just seems like it could slow down your metabolism. Maybe you eat more, move less. That could, maybe you eat worse food. It increases your cholesterol. I could kind of see it. But duloxetine, venlafaxine, and desvenlafaxine, I mean, I think of those as more like an energy promoting, like kind of increasing your metabolic rate. Like, and they weren't on the weight gain section, right? They, as far as like when I listed the weight gain, we had milnacipran in there, the SNRI, but we didn't have any of the other these three. But for some reason, they seem to increase cholesterol, whereas other stuff doesn't. So if you got a patient talking about cholesterol increase and they're on one of these medications, perhaps you should change it, because perhaps this is the cause. Like, this is like a known risk now. These antidepressants can increase cholesterol. Not something we talk about. And then also for duloxetine, glucose. So there was increased glucose, and it was the only one. So duloxetine may not be so great metabolically. So, I mean, that's another of the ones I always, really like duloxetine. Maybe I'll have to knock it down a rung. I think I had it in my A or B tier. I might have to knock it down. And then heart rate, blood pressure. This one is not surprising. The SNRIs, Leeville milnacipran being the worst of the SNRIs, which makes total sense because it's got the highest norepinephrine to serotonin ratio, so that makes complete sense. And then the TCAs, which also have a lot of norepinephrine effect, were higher than that, so that makes sense as well. Looking at QTC, this was really awesome here. So the tricyclics were higher than placebo, but none of the medications were terribly significant. And I know we've got this risk on Celexa and or citalopram, escitalopram, fluoxetine. A lot of these have risks for QTC, but it just doesn't increase it that much. So that was actually kind of great to see that. The tricyclics were the biggest offenders there, but still they was not huge. I'm saying, like, if you combine it with other QTC prolongating medications, perhaps there's a synergistic effect there that you need to be concerned about. Next thing they looked at was liver function, AST, ALT. so kind of in order here, paroxetine raises them a little bit, and then vilazodone was a little more than that, desvenlafaxine a little more than that, levomirazaperin a little bit more than that, and then duloxetine. We are aware that duloxetine, you might need to check the liver enzymes for that one. But at the same time, they said none of them were terribly significant. These were very small increases. So I think just to kind of be aware that those are the ones that would be the most likely to cause it, and in that order is just something to kind of keep in the back of your mind. And then sodium changes, none were significant. Now we know we have the risk of hyponatremia on serotonergic medications, but like it's such an insignificant issue that like it just didn't show up at all when they looked at the study. I mean, it still can happen, but it's just so rare that it's just not going to be enough to push the numbers. And like it doesn't even drag them down that much, right? So it's just some patients must be sensitive to it, and that's the thing you need to be aware of about all this stuff. Some patients are going to be more sensitive. You can't look at population data and just apply that to an individual patient. So I think that's a really cool article. The effects of antidepressants on cardiometabolic and other physiological parameters, a systematic review and network meta-analysis. Check it out. All right, next. Again, another phase 3 trial here. This is on a medication called roluperidone. Kind of sounds like risperidone. It's an antipsychotic, but it's a 5-HT2A antagonist and sigma-2 antagonist. They're trying to get approval for the treatment of negative schizophrenia symptoms. The FDA has previously rejected this, but they're resubmitting it. So they're starting another phase 3 trial. Like this drug company really thinks this thing works. We have no drug that's FDA approved for negative symptoms. Positive symptoms we can control pretty well. We do have some trouble with the negative symptoms. So, perhaps this medication could be helpful. So keep your eye on it. But the fact that it's been trying for so long and not have much success tells me that like if they ever do get approval, it's probably going to be like very minimal impact. And also the fact that they're taking so long means that their patent's going to run out by the time it gets approved, if it does. So just kind of be aware, roluperidone. And then, here's some interesting stuff kind of related to that. Risperidone, the long-acting injectable, we haven't talked about these yet, but if you look at the long-acting injectables for schizophrenia, we have a few different arapiprazoles. We've got Maintaina, we've got Aristata, and then there's like Austata, something. Those two are related. I think you have to use them both. You start with one and go to the other one. I can't remember exactly right now. And then you've got Zyprexa. It's got an LAI, but it's got the black box warning on it, which makes it hard to use. You've got paliperidone as well. So that's the metabolite of risperidone. That's the one I really like to use. And the good thing is that one has the 3 and the 6 month beyond just the 1 month. So that's why I really do like that one. And then we've got the first generation ones. We've got the haloperidol and what is it? Prolixin, like perfenazine. I can't remember. I think it's perfenazine. I get a lot of those first generation generic names confused, but it's Prolixin and Haldol. We've got the long actings, and then you've got risperidone. And so a lot of I know like low income and like prisoners are on like Haldol deck because it's so cheap. But here's good news: Risperdal Consta, right? So that was the downside with Consta is it has to be given every 2 weeks, but the good news is that it's now generic. So now there is a generic version of Risperdal or Risperidone Risperdal Consta. So I don't know what they're calling the generic product, but this is now generic, meaning that it's going to be more affordable. And so for those that were like stuck with the Haldol and Prolixin LAIs, we now have a second generation LAI available. However, it's only every 2 weeks, but good news. And then there's actually a couple more risperidone LAIs that have come out in the last few years. I'm forgetting the name of one of them, but another one is called Uzedy. Um, and good news for Uzedy is that it's now approved not just for schizophrenia, but as an adjunct for bipolar 1. So if you've got a patient on bipolar 1, or they've got bipolar 1, and you've got them on risperidone, and it's really helping them in addition to maybe lithium, um, or you don't have them, maybe you've got them on a different second generation, but you'd like to put them on an LAI, and so perhaps you were giving them an LAI, but it's not covered by insurance because it's not approved. Risperidone is approved, but like the LAI isn't. Uzedy is now approved, and so the other long-acting injectable that is approved as an adjunct for bipolar 1 is um, uh, uh, Maintaina. So aripiprazole long-acting injectable Maintaina has been approved as an adjunct for bipolar 1, and now risperidone's Uzedy is another option. All right, so now we have a second option, LAI approved for adjunct bipolar 1. All right, and then I've got one last paper here. So this is Zhang et al. Um, Clinical efficacy. This is interesting. Remember when I talked about that um, fecal microbiota transplantation uh, case report in Australia for bipolar disorder, and like her bipolar disorder was just gone after like her husband, who's like a botanist or something, like decided to just like do this, and it worked. And like we're just like not studying it, and I was like, we need to study this. This is awesome. This is a potential cure. It's like, this is why I like the Ibogaine, like a one-time thing where you're not chronically having to take some med. You can just do one-time treatment and they're like cured. Of course, we don't know that. It's just one case, but it was very compelling, and I think we should study it. Well, here we got another one: clinical efficacy of fecal microbiota transplantation in alleviating depressive symptoms. So this is not bipolar disorder. This is depression. A meta-analysis of randomized trials from Frontiers Psychiatry 2025. And the effect size was like massive on this. 1.0. It was actually over 1.0. There were several effect sizes they listed for different situations, and I just like said, okay, you can look at the paper if you want all the details, but what you need to know is that the effect size was over 1.0, which is huge. If you listen to this podcast, you know about effect sizes, and you know that antidepressants average around 0.3. And so to have like a treatment, and the thing is, this is like once again a one-time thing, potentially at 1.0. And that when they looked at patients with inflammatory bowel syndrome, IBS, they had even a bigger effect. And then also those that had a direct GI delivery, so I guess like a suppository versus something that you swallow, and you're thinking, I'm not going to swallow someone's poo. And it's like, it's not poo. It's like, it comes from the poo and it's cleaned, and it's basically just their microbiota, and it's in a pill and you swallow it. It sounds gross, but if you want to be grossed out, everything you put in your mouth it's probably at some point in the butt of some animal or human being at some point in the history of the universe, multiple times. So millions of times over, this organic material that you're putting in your mouth has been through the digestive tracts of many, many different creatures over millions of years, hundreds of millions of years. So just live with it. It's not the same thing. You're not eating poo. Or you are, and just consider the fact that everything you eat's poo. So, but they did find that the suppository version of this was more effective. If that makes you feel better, it's like, okay, I want to do this, but like, oh, I can do the suppository version and it's more effective. Great. So they found in IBS and direct GI delivery, it was more effective. But like this is, I mean, this is a meta-analysis of randomized trials. So like, that's pretty good data. This is, I mean, I'm guessing this was done in China. It was a bunch of Chinese names on here. The U.S. has gotten really strict about using these fecal microbiota transplants because they think that they're dangerous. But like, it's kind of like the Schedule One drugs. Like, we're getting signal that stuff like this could be effective. It's like ketogenic diet, Schedule One drugs, fecal microbiota transplantation. These are things that we're seeing like huge effects from. We need to look into it to figure out if this stuff actually works. Because hey, if we can do a one-time treatment, you don't have to take a drug for the rest of your life, and it works better. Man, that's great. So I'm really excited. Like, I'm Mr. Microbiota. Like, I love me some microbiota. So I gut microbiota. Like I think this is like this drives so much of like what makes us healthy, and that we could be doing a treatment related to that helps with depression. That's just like super incredible to me. So that's the last one we went over. These are all papers, and I mean the papers, phase trials that have come out, just new approvals, news, etc., that's come out since 2 months ago. That's a lot of stuff, and I imagine it's probably hard for like all of you to stay up to date on everything that's going on with psychiatry. And so here I'm doing it. In 2 hours, you get to learn everything you needed to know during your car ride that has happened in the last 2 months. And hopefully I'll be able to keep doing this, and that you're interested in hearing about it and getting this kind of like digest version. So I want to thank you for joining me today. We'll be back again probably in another couple months with another update in psychiatry, and I will see you then.